Hey, future nurses, get ready to level up your NCLEX prep with today's power-packed video, Pharmacology of Hematological, where we break down 18 must-know questions that could absolutely show up on your exam. We're talking about the most tested hematology drugs like Heparin-warfarin, Enoxaparin, Epoetin, alfa, Hydroxyurea, and more. You'll learn how to spot red flags, monitor labs, manage side effects, and make smart clinical decisions. Everything you need to think like a nurse and pass with confidence. Each question comes with crystal clear explanations to boost your understanding and sharpen your clinical judgment. And here's the best part. We drop new NCLEX videos every single day, packed with high-yield topics, tips, and questions to keep you ahead of the game. So hit that follow button, stay with us till the end, and let's crush these pharmacology questions together. One quick heads up before we begin. If you're serious about passing the NCLEX, the complete NCLEX Review online course has every resource you need. 100 animated hours, 500 in-depth lectures, 5,000 questions, 500 NGN case studies, and 15 simulated exams. You'll also get a 1-year NCLEX ebook to study anytime. Right now, get 70% off. Limited time offer. Click the link below and take your first step toward passing. Let's begin with a foundational pharmacology question that highlights a critical medication often used after surgery. This is one of those must-know topics that shows up on the NCLEX and has direct clinical application. Let's test your knowledge with question number 1. The nurse is reviewing the medication list for a client who has been newly prescribed Fondaparinux following orthopedic surgery. The nurse understands that the primary therapeutic purpose of Fondaparinux is for the prevention or treatment of which of the following conditions. Now, take a close look at the answer choices. Option A. Immune thrombocytopenic purpura. Option B. Venous thromboembolism. Option C. Beta thalassemia major. Option D. Megaloblastic anemia due to folate deficiency. Think carefully here. What is the main reason a provider would order Fondaparinux, especially after orthopedic surgery? The correct answer is option B, venous thromboembolism. Let's walk through the reasoning behind this. Fondaparinux is a synthetic anticoagulant that works by selectively inhibiting activated factor 10A. This action interrupts the blood coagulation process and helps prevent the formation or extension of clots. It is frequently used in both the prevention and treatment of venous thromboembolism, which includes deep vein thrombosis and pulmonary embolism. These are serious conditions that can occur after surgery, particularly orthopedic procedures, where the risk of clot formation is elevated due to immobility and tissue injury. In contrast, option A, immune thrombocytopenic purpura, is a condition characterized by low platelet counts caused by immune system activity. Giving an anticoagulant in this scenario would further increase bleeding risk, making Fondaparinux inappropriate. Option C, beta thalassemia major, is a hereditary blood disorder involving defective hemoglobin production. Treatment focuses on regular blood transfusions and iron chelation therapy, not anticoagulants. Option D, megaloblastic anemia due to folate deficiency, is managed with folic acid supplementation and is unrelated to clotting or anticoagulation therapy. Clinically, Fondaparinux is administered once daily through a subcutaneous injection and has the advantage of not requiring regular laboratory monitoring, such as activated partial thromboplastin time or international normalized ratio. It is also less likely to cause heparin-induced thrombocytopenia because it does not bind to platelet factor 4. However, it is contraindicated in clients with severe kidney impairment, especially those with a creatinine clearance below 30 milliliters per minute, due to the elevated risk of bleeding. This medication is frequently included in postoperative protocols for orthopedic and abdominal surgeries, making it a high-yield topic for both the NCLEX and real-world nursing practice. Now let's shift to another high-yield anticoagulant frequently tested on the NCLEX. This one focuses on client education and medication safety with Apixaban, a drug often prescribed for atrial fibrillation. Understanding the difference between Apixaban and warfarin is absolutely crucial for nursing practice and safe discharge teaching. Time to dive into the next one. Question number 2. A nurse is reviewing discharge instructions with a client who has been prescribed Apixaban for stroke prevention due to atrial fibrillation. Which of the following statements made by the client indicates a need for further teaching? Let's now review the answer choices one by one. Option A, I will need to have my blood tested frequently to monitor my international normalized ratio while on this medication. Well, sirs, option B. I will inform my dentist that I am taking Apixaban before any dental procedures. Zrenia option C. I should avoid taking over-the-counter ibuprofen unless approved by my healthcare provider. Option D. I should maintain a balanced diet and avoid excessive intake of foods high in vitamin K like leafy greens. Take a moment to think through what makes Apixaban different from other anticoagulants in terms of monitoring and dietary restrictions. The correct answer is option D. I should maintain a balanced diet and avoid excessive intake of foods high in vitamin K, like leafy greens. Let's break it down together. This statement suggests the client believes Apixaban has dietary interactions similar to warfarin, which it does not. Warfarin requires consistent intake of vitamin K because it directly interferes with vitamin K-dependent clotting factors. However, Apixaban works by directly inhibiting factor 10A, which means it is not affected by vitamin K levels at all. Clients taking Apixaban do not need to restrict or avoid leafy green vegetables, and this misconception signals the need for further teaching. Option A also seems like a common point of confusion. Clients often associate anticoagulants with frequent blood testing, but Apixaban is designed to offer a more convenient alternative to warfarin. It does not require routine laboratory monitoring such as international normalized ratio or activated partial thromboplastin time. Option B is a correct and safe statement. Anyone taking an anticoagulant must inform their dentist before procedures because of increased bleeding risk. Option C is also correct because over-the-counter medications like ibuprofen can increase the chance of gastrointestinal bleeding when combined with Apixaban. The client should always check with their healthcare provider before using such medications. Clinically, Apixaban offers many advantages. It has predictable dosing, fewer interactions, no need for regular blood tests, and minimal dietary restrictions. However, it must be taken consistently at the same time each day, and stopping it suddenly without medical supervision could increase the risk of stroke or other thromboembolic complications. For NCLEX success, always remember that Apixaban is not the same as warfarin, especially when it comes to diet and lab monitoring. Let's keep the momentum going with another important NCLEX scenario, this time focusing on post-operative care and clot prevention. After major orthopedic surgeries like a total hip replacement, preventing venous thromboembolism becomes a top priority, and nurses must be ready to anticipate the correct pharmacologic intervention. Let's dive right into it with question number 3. A nurse is caring for a post-operative client following total hip replacement surgery. The healthcare provider has prescribed pharmacologic prophylaxis to reduce the client's risk of developing a venous thromboembolism. Which of the following medications should the nurse anticipate administering? Now let's review the options closely. Option A, Enoxaparin. Option B, hydrochlorothiazide. Option C, carbamazepine. Option D, clopidogrel. Think through each option carefully. Only one of them is routinely used to prevent deep vein thrombosis and pulmonary embolism after surgery. The correct answer is option A, Enoxaparin. Let's walk through why this choice is the most appropriate. Enoxaparin is a low molecular weight heparin that is commonly prescribed for venous thromboembolism prevention in clients who have undergone orthopedic procedures, such as total hip or knee replacement. It is administered subcutaneously and has the advantage of not requiring routine monitoring with activated partial thromboplastin time. Its predictable anticoagulant effect, longer half-life, and lower risk of causing heparin-induced thrombocytopenia make it a preferred choice for post-operative prophylaxis. Option B, hydrochlorothiazide, is a thiazide diuretic used to manage blood pressure and reduce fluid retention. It has no role in anticoagulation and does not prevent clot formation. Option C, carbamazepine, is an anticonvulsant and mood stabilizer used for seizure disorders and bipolar disorder. It has no effect on clot prevention or anticoagulant properties. Option D, clopidogrel, is an antiplatelet agent that works to reduce the risk of arterial clots, such as those that cause strokes or heart attacks. However, it is not the standard of care for preventing venous thromboembolism after orthopedic surgery. While antiplatelets may be used in select cases, low molecular weight heparins like Enoxaparin are the first-line agents in high-risk surgical clients. Clinically, Nurses should be aware that Enoxaparin is usually given once or twice daily, depending on the client's renal function and bleeding risk. It is contraindicated in clients with active bleeding, severe kidney impairment, or recent spinal or epidural procedures. Nurses must educate clients not to rub the injection site, monitor for signs of bleeding, and be alert to symptoms like new bruising or low platelet counts. Always be aware of the timing of spinal anesthesia and ensure appropriate spacing of doses to avoid complications like spinal hematomas. These kinds of questions reflect real-life clinical judgment and are frequently seen on the NCLEX, so keep this one in your high-priority review list. Now let's turn our attention to a classic hematological disorder that often appears on the NCLEX, pernicious anemia. This condition is more than just low hemoglobin. It involves a very specific nutritional deficiency due to a problem with absorption, and recognizing how to treat it is crucial for nurses. Next up on your NCLEX prep journey, question number 4. A nurse is reviewing the laboratory results of a client recently diagnosed with pernicious anemia, which is characterized by vitamin B12 deficiency due to impaired intrinsic factor production. The nurse should anticipate a prescription for which of the following medications to address this condition? Let's take a moment to examine the options. Option A, pyridoxine. Option B, cyanocobalamin. Option C, ferrous sulfate. Option D, ascorbic acid. As you evaluate each one, remember that the key to treating this condition lies in addressing what the body cannot absorb on its own. The correct answer is option B, cyanocobalamin. Now, here's why this is the right choice. Pernicious anemia is a type of macrocytic anemia that results from a deficiency of vitamin B12, also known as cyanocobalamin. The root cause is usually an autoimmune destruction of the gastric parietal cells that produce intrinsic factor, a protein needed for vitamin B12 absorption in the intestines. Without intrinsic factor, no matter how much vitamin B12 is in the diet, it cannot be absorbed effectively through the gastrointestinal tract. That is why cyanocobalamin must be administered intramuscularly or subcutaneously, bypassing the gastrointestinal system altogether. Clients with pernicious anemia typically require lifelong vitamin B12 therapy. Option A, pyridoxine, is vitamin B6, which is important for nerve function and is often used for isoniazid-induced neuropathy, but it has no therapeutic effect on vitamin B12 deficiency. Option C, ferrous sulfate, is used to treat iron deficiency anemia, which is a different type of anemia, typically microcytic rather than macrocytic, and is not related to intrinsic factor or vitamin B12. Option D, ascorbic acid or vitamin C, can enhance iron absorption and support immune health, but does not treat the underlying issue in pernicious anemia. Clinically, untreated vitamin B12 deficiency can lead to serious and irreversible neurological damage, including paresthesia, balance problems, cognitive decline, and even psychiatric symptoms. Additional signs include glossitis, fatigue, and elevated mean corpuscular volume on laboratory results. Early recognition and prompt treatment with cyanocobalamin can reverse symptoms and prevent long-term complications. This is a textbook example of the kind of scenario you can expect on the NCLEX, so be sure to recognize the difference between vitamin deficiencies and the specific conditions they are designed to treat. Let's dive into a crucial oncology question. This one focuses on chemotherapy safety, and knowing when to escalate care is absolutely vital. When a client is receiving cytotoxic agents like Doxorubicin, the nurse must be alert for subtle but serious signs of complications. Let's put your knowledge to the test with question number 5. A nurse is monitoring a client who is receiving Doxorubicin as part of chemotherapy for breast cancer. Which of the following assessment findings requires immediate follow-up by the nurse? Now take a moment to go through the choices. Option A, mild nausea after meals. Option B, fever of 38.5 degrees Celsius or 101.3 degrees Fahrenheit. Option C, temporary hair thinning. Option D, fatigue during daily activities. Think carefully. Which one of these findings may signal a medical emergency? The correct answer is option B, fever of 38.5 degrees Celsius or 101.3 degrees Fahrenheit. Let's break down why this is the most urgent red flag. Doxorubicin is a powerful anthracycline chemotherapy drug known for its strong myelosuppressive effects. This means it significantly lowers the white blood cell count, placing clients at high risk for infections due to neutropenia. When a client receiving chemotherapy presents with a fever, even a low-grade one, it must be taken very seriously, as it could be the only early sign of a life-threatening condition known as febrile neutropenia. In this state, the immune system is too weak to respond effectively, and even minor infections can become rapidly fatal. This situation requires immediate follow-up, including blood cultures, a complete blood count to check for neutropenia, and prompt initiation of broad-spectrum intravenous antibiotics. Option A, mild nausea, is a common side effect of many chemotherapy drugs and is generally managed with antiemetics. While it should not be ignored, it does not require urgent intervention. Option C, hair thinning, is expected with Doxorubicin because it targets rapidly dividing cells, including hair follicles. It can be emotionally distressing for clients but is not a clinical emergency. Option D, fatigue, is another frequent side effect of chemotherapy and can be due to anemia, the cancer itself, or emotional stress. It requires monitoring and supportive care but not immediate action unless it becomes severe or disabling. Clinically, Doxorubicin also carries a risk of cardiotoxicity with long-term use, so periodic echocardiograms and close monitoring of the complete blood count are essential. Clients must be taught to report any sign of fever right away, even if they feel otherwise fine. This is the kind of high-risk, high-stakes nursing scenario that shows up on the NCLEX. So always think, when a client on chemotherapy has a fever, treat it like an emergency until proven otherwise. Before we break down this question, here's a game changer. The complete NCLEX Review online course gives you 100 hours of animation, 500 hours of recorded content, 5,000 essential questions, 500 NGN-style clinical case studies, and 15 full mock exams. Plus, you'll get a detailed NCLEX ebook with 1-year access. Get in now. 70% off, but not for long. The link's in the description. Thousands of future nurses are already ahead. Don't get left behind. Let's move into an important pediatric question that highlights client education, a critical part of safe medication administration, especially when caring for children. Iron deficiency anemia is a common condition, and nurses must provide clear instructions to caregivers to ensure effective and safe treatment. Here comes another high-yield scenario. Question number 6. The nurse is educating the parent of a 12-year-old child recently diagnosed with iron deficiency anemia who has been prescribed ferrous sulfate elixir. Which of the following instructions should the nurse include in the teaching? Let's now go through each option carefully. Option A. Crush any leftover tablets and mix them with pudding for easier swallowing. Option B. Dilute the iron elixir in juice or water before giving it to your child. NCLEX component placement. Option C. Give the medication with a glass of milk to protect the stomach. Zrania. Option D. Have your child brush their teeth before taking the medication to reduce staining. Think about both the absorption of iron and ways to minimize the side effects, especially in younger clients. The correct answer is option B. Dilute the iron elixir in juice or water before giving it to your child. Now let's understand why this is the best instruction. Ferrous sulfate elixir is a liquid iron supplement often prescribed for children. And while it is effective, it can cause teeth staining and has an unpleasant metallic taste. Diluting it in juice or water improves its taste and helps reduce the chance of dental staining. Using a straw and encouraging the child to rinse their mouth or brush their teeth afterward further helps prevent discoloration. Juice, especially those rich in vitamin C like orange juice, also enhances iron absorption. Option A is incorrect because crushing leftover tablets and mixing them with pudding is not appropriate, especially when an elixir form is already prescribed. Doing so may alter absorption and could increase the risk of tooth staining. Option C is also incorrect because milk contains calcium, which inhibits iron absorption. Giving iron supplements with dairy products significantly reduces their effectiveness. Iron should be administered either on an empty stomach or with foods that do not interfere with absorption if gastrointestinal discomfort occurs. Option D sounds reasonable at first, but brushing the teeth before taking iron will not prevent staining. The correct approach is to brush or rinse the mouth after administration. Clinically, iron supplements can cause common side effects like constipation, nausea, and dark-colored stools. To maximize absorption and minimize discomfort, space iron from calcium-containing products and antacids by at least 2 hours. These details are not only important for safe client care, but are exactly the kind of subtle knowledge the NCLEX is designed to test. Let's now shift into a clinical judgment question that highlights both pharmacology and lab monitoring, something you absolutely must know for the NCLEX. When administering anticoagulants like Enoxaparin after surgery, it is critical to know what lab values to prioritize in order to catch serious complications early. This one's important. Do not miss question number 7. A nurse is preparing to administer Enoxaparin to a hospitalized client following abdominal surgery for venous thromboembolism prophylaxis. Which of the following laboratory values is most important for the nurse to monitor while the client is receiving this medication? Let's walk through the options carefully. Option A, platelet count. Option B, serum creatinine. Option C, hemoglobin, E-NOC. Option D, alanine aminotransferase. Think about which value will help you detect the most serious and immediate complication associated with Enoxaparin. The correct answer is option A, platelet count. Now let's break down the clinical reasoning behind this. Enoxaparin is a low molecular weight heparin commonly used to prevent venous thromboembolism after surgical procedures. One of the most dangerous potential side effects of this medication is a condition known as heparin-induced thrombocytopenia. This is a rare but severe immune-mediated complication where the platelet count drops significantly, often by more than 50%, yet paradoxically increases the risk of blood clots. Monitoring the platelet count allows early detection and immediate discontinuation of the drug to prevent life-threatening thrombotic events. Option B, serum creatinine, is also important to consider because Enoxaparin is cleared by the kidneys and dosage adjustments may be necessary in clients with impaired renal function. However, it is not the most critical lab for identifying the most urgent complication. Option C, hemoglobin. A1C is used to assess long-term blood glucose control in diabetic clients and is unrelated to anticoagulant safety. Option D, alanine aminotransferase, is a liver enzyme and is not directly influenced by enoxaparin. Unless liver dysfunction is suspected, it is not a monitoring priority. Clinically, enoxaparin does not require regular activated partial thromboplastin time or international normalized ratio testing, which distinguishes it from other anticoagulants like unfractionated heparin or warfarin. It is administered subcutaneously, typically into the abdomen, and the air bubble in the pre-filled syringe should not be expelled. It helps prevent medication loss and reduces bruising. After injection, do not massage the site, as this could lead to hematoma formation. Use caution in clients with active bleeding, recent spinal procedures, or severe kidney disease. This kind of monitoring question is very testable on the NCLEX and reinforces the need to match each medication with its specific lab priorities. Time for another high-yield clinical decision-making question. This one highlights medication safety with high-alert drugs like unfractionated heparin. When starting a continuous infusion for a client with acute coronary syndrome, your very first action can make all the difference in preventing complications. Time to apply your critical thinking. Question number 8. The nurse receives a new prescription to initiate a continuous infusion of unfractionated heparin for a client with acute coronary syndrome. Before starting the infusion, which of the following actions should the nurse take first to ensure safe and accurate medication administration? Now, let's go over each of the options thoughtfully. Option A. Ask the client when they last took aspirin or clopidogrel. Option B. Weigh the client using a calibrated hospital scale. Option C. Request a peripheral intravenous line with a 16-gauge needle. Option D. Check the client's serum potassium level. Think carefully about what is most essential to perform first to ensure proper medication dosing and avoid harm. The correct answer is option B. Weigh the client using a calibrated hospital scale. Let's break down why this action takes priority. Unfractionated heparin is dosed based on the client's actual body weight in units per kilogram per hour, and even small dosing errors can result in either under-anticoagulation or serious bleeding. Estimating a client's weight is never safe when initiating a weight-based medication like heparin. A precise, up-to-date weight ensures that both the initial bolus dose and the continuous infusion rate are accurate. Option A, asking about aspirin or clopidogrel use, is certainly part of a comprehensive medication review and does matter since these drugs increase bleeding risk. However, this information does not directly impact the initial dosing of unfractionated heparin and should not delay its start if the prescription is already in place. Option C, requesting a 16-gauge intravenous line is unnecessary. Heparin does not require a large-bore needle like those used for blood transfusions or trauma resuscitation. A smaller gauge peripheral intravenous catheter is sufficient and safe for heparin infusion. Option D, checking the serum potassium level, is relevant for clients with cardiac issues and those on diuretics or angiotensin-converting enzyme inhibitors, but it does not impact the immediate initiation of a heparin drip. What truly matters most before beginning the infusion is obtaining an accurate body weight. Clinically, unfractionated heparin is a fast-acting anticoagulant that requires close monitoring. Baseline laboratory values like activated partial thromboplastin time and platelet count are typically drawn before starting therapy to assess bleeding risk and to monitor for heparin-induced thrombocytopenia. Also, because heparin is considered a high-alert medication, its administration often requires double-check verification by 2 licensed nurses. These details are not only essential for safe practice, but are exactly the kind of knowledge that the NCLEX loves to test. We are halfway there. Now let's focus on a high-risk complication that every nurse must be ready to act on. Heparin-induced thrombocytopenia is a life-threatening immune response that paradoxically increases clotting risk despite low platelet levels. Knowing how to respond and what medications to avoid is critical for both client safety and NCLEX success. You are doing great. Now take on question number 9. A nurse is caring for a hospitalized client with venous thromboembolism who has now developed heparin-induced thrombocytopenia on day 5 of unfractionated heparin therapy. After discontinuing the heparin infusion, which of the following medications should the nurse anticipate being prescribed to continue anticoagulation therapy? Let's go through the options. Option A, Enoxaparin. Option B, dabigatran. Option C, ibuprofen. Option D, filgrastim. Think about which of these options provides effective anticoagulation without triggering further immune-related platelet destruction. The correct answer is Option B, dabigatran. Let's walk through why this is the safest and most appropriate choice. Dabigatran is a direct thrombin inhibitor and is one of several non-heparin anticoagulants used to continue anticoagulation in clients who develop heparin-induced thrombocytopenia. Even though heparin must be stopped immediately when heparin-induced thrombocytopenia is suspected, the client still remains at high risk for clot formation and must remain anticoagulated. Dabigatran provides this coverage without interacting with the immune system in the same way as heparin. Option A, Enoxaparin, is a low molecular weight heparin and must also be avoided in heparin-induced thrombocytopenia because it can worsen the immune-mediated reaction. It is still a heparinoid, meaning it shares enough similarity with unfractionated heparin to potentially trigger or prolong heparin-induced thrombocytopenia. Option C, ibuprofen, is not an anticoagulant at all. It is a non-steroidal anti-inflammatory drug, and it actually increases the risk of bleeding, especially in a client with low platelets, making it both ineffective and unsafe. Option D, filgrastim, is used to stimulate white blood cell production in neutropenic clients, often after chemotherapy, but it does not help with platelet destruction and is completely unrelated to clot prevention. Clinically, heparin-induced thrombocytopenia typically appears between days 4 and 10 after starting heparin and involves a sudden drop in platelet count by 50% or more. What makes it especially dangerous is that it paradoxically increases the risk of both venous and arterial thrombi, even as platelet levels drop. The first step in treatment is to discontinue all forms of heparin, including low molecular weight heparins like enoxaparin. Anticoagulation must be continued using non-heparin agents like dabigatran, Fondaparinux, argatroban, Apixaban, or Hydroxyurea. Monitoring includes watching platelet counts, checking for new signs of thrombosis, and reviewing kidney function, particularly for medications like dabigatran that are excreted through the kidneys. Also remember, warfarin should not be started during active heparin-induced thrombocytopenia because it may worsen thrombosis and cause complications like venous limb gangrene. This is a classic example of how nurses must act quickly to prevent further harm, and this type of question is a staple on the NCLEX. Let's move ahead with a question that focuses on evaluating medication effectiveness, something you will often need to do when managing chemotherapy side effects. Understanding what each medication is designed to do helps nurses recognize whether treatment is working or if adjustments are needed. Let's challenge your clinical judgment with question number 10. The nurse is evaluating the effectiveness of Oprelvekin in a client undergoing chemotherapy. Which of the following laboratory findings best indicates a therapeutic response to the medication? Now, let's go through the options carefully. Option A, platelet count of 155,000 per cubic millimeter. Option B, hemoglobin of 13.5 grams per deciliter. Option C, absolute neutrophil count of 3,000 per cubic millimeter. Option D, serum ferritin level of 90 nanograms per milliliter. To get this question right, focus on what Oprelvekin is designed to treat. The correct answer is Option A, platelet count of 155,000 per cubic millimeter. Let's break down why this reflects a therapeutic response. Oprelvekin is a recombinant human interleukin 11 that specifically stimulates the production of platelets by encouraging megakaryocyte proliferation in the bone marrow. It is used in clients receiving myelosuppressive chemotherapy to reduce the risk of thrombocytopenia, which is a dangerously low platelet count that increases the risk of bleeding. A platelet count within the normal range, such as 155,000 per cubic millimeter, shows that the medication is working and has successfully supported platelet recovery. Option B, a hemoglobin of 13.5 grams per deciliter, is a normal value but relates to red blood cell production, not platelet counts. Oprelvekin does not stimulate red blood cell production. Medications like Epoetin alfa are used for that purpose. Option C, an absolute neutrophil count of 3,000 per cubic millimeter, indicates a healthy immune response and would reflect the effectiveness of a medication like filgrastim, which targets white blood cell production. Again, that is not the purpose of Oprelvekin. Option D, serum ferritin, measures the body's iron stores and is relevant in assessing iron status or iron deficiency anemia. It does not reflect platelet activity or production, and is not a relevant marker when evaluating the effects of Oprelvekin. Clinically, Oprelvekin is used to prevent severe thrombocytopenia and reduce the need for platelet transfusions during chemotherapy. The therapeutic response typically begins within 5 to 9 days of administration and lasts about 7 days after the last dose. Nurses should monitor for side effects such as fluid retention, increased heart rate, atrial arrhythmias, or redness in the eyes. Understanding which lab values align with which medication is a key NCLEX skill. So remember that Oprelvekin targets platelets, not red cells or neutrophils. Right before we get into the question, let me ask you this. Is your NCLEX prep complete? If not, the complete NCLEX review course gives you 100 hours of animations, 500 hours of lecture content, 5,000 high-yield questions, 500 NGN case studies, and 15 mock exams, all with a year-long ebook. Save 70% today, but the deal won't last. Click the description link to enroll and start strong. Now let's move into a question that combines pharmacology with client education, an area where nurses play a critical role, especially when it comes to managing chronic conditions like kidney disease. Understanding what to teach about medications like Epoetin alfa is essential for promoting safety and effectiveness in care. Another step closer to NCLEX success. Question number 11. The nurse is providing medication education to a client who has been newly prescribed Epoetin alfa for anemia secondary to chronic kidney disease. Which of the following statements made by the nurse is most appropriate to include in the teaching? Let's walk through each of the options. Option A, this medication will increase your neutrophil count to reduce your risk of infection. Component placement. Option B, you may experience mild hair loss during treatment with this medication. Зрение. Option C. Option D. This medication must be taken with orange juice to enhance its absorption. Keep in mind that correct education should reflect the medication's purpose, route, and side effects. The correct answer is Option C. This medication may cause an elevation in your blood pressure and should be monitored regularly. Let's talk about why this is the most appropriate teaching point. Epoetin alfa is a synthetic form of erythropoietin, used to stimulate the production of red blood cells in clients with anemia, particularly those with chronic kidney disease. As it increases red blood cell mass and blood viscosity, it can also raise blood pressure, making regular blood pressure monitoring essential. This is especially important because many clients with chronic kidney disease already struggle with hypertension, and further increases can become dangerous or even life-threatening. Option: A is incorrect because Epoetin alpha does not increase neutrophils. That is the action of filgrastim, a granulocyte colony-stimulating factor used to treat neutropenia. Option B is also incorrect, as hair loss is not a typical side effect of Epoetin alpha. It is more associated with chemotherapy drugs or cytotoxic treatments. Option D is misleading because Epoetin alpha is not taken orally. It is administered subcutaneously or intravenously and does not rely on vitamin C for absorption. That teaching point actually applies to oral iron supplements. Clinically, the goal of Epoetin alpha therapy is to raise hemoglobin and hematocrit levels just enough to reduce the need for blood transfusions. The target hemoglobin is generally kept below 11 grams per deciliter to avoid increasing the risk of serious complications like stroke, myocardial infarction, or thromboembolic events. This medication may be used alongside iron therapy to ensure adequate iron stores for red cell production, but it does not require any dietary enhancements like orange juice. This type of patient education question is highly testable on the NCLEX because it challenges your understanding of both pharmacologic action and client safety. Do not miss this one. Sickle cell disease is a highly tested topic on the NCLEX, especially when it comes to preventing painful vaso-occlusive crises. Knowing which medication helps reduce sickling episodes can make a major difference in long-term client outcomes. Let's test your nursing instincts with question number 12. A nurse is reviewing the medication orders for a client admitted with a diagnosis of sickle cell disease who has a history of frequent vaso-occlusive crises. Which of the following prescriptions should the nurse anticipate to reduce the frequency of sickling episodes? Let's go through the options together. Option A, Hydroxyurea. Option B, Azathioprine. Option C, amitriptyline. Option D, diltiazem. Think carefully about which medication is designed to target the underlying cause of sickling in red blood cells. The correct answer is Option A, Hydroxyurea. Now let's explore why this medication is the best choice for clients with moderate to severe sickle cell disease. Hydroxyurea is the gold standard in long-term pharmacologic management of sickle cell disease, especially in those who experience repeated painful crises, acute chest syndrome, or severe anemia. Its main mechanism is increasing the production of fetal hemoglobin, which helps prevent the polymerization of sickle hemoglobin, the type that causes red blood cells to sickle. When fetal hemoglobin levels are increased, red blood cells remain more flexible, maintain their shape better, and are less likely to block blood vessels. This results in fewer episodes of pain, reduced need for blood transfusions, and fewer hospitalizations. Option B, azathioprine, is an immunosuppressive medication used primarily in autoimmune diseases and transplant clients, and it has no therapeutic role in sickle cell disease. Option C, amitriptyline, is a tricyclic antidepressant often prescribed for chronic neuropathic pain, but it has no impact on red blood cell morphology or hemoglobin structure, so it will not help with vaso-occlusion. Option D, diltiazem, is a calcium channel blocker used for managing blood pressure and certain cardiac conditions like atrial fibrillation, but it does nothing to influence hemoglobin or prevent sickling. Clinically, hydroxyurea is highly effective, but must be used cautiously. It can suppress bone marrow function, so nurses must monitor for neutropenia, thrombocytopenia, and worsening anemia. Regular complete blood count testing is required, and the medication is contraindicated in pregnancy due to teratogenic effects. Educating clients about the importance of adherence and monitoring helps ensure both safety and success with therapy. This kind of question ties together pharmacology, pathophysiology, and safety monitoring, all core to NCLEX preparation. Moving ahead with another highly testable NCLEX topic, this one focuses on identifying adverse effects of a commonly used anticoagulant. As nurses, it's not just about giving the medication. It's also about recognizing when something is going wrong. Focus in. This could be a potential exam question. Question number 13. A nurse is assessing a client who has been receiving prescribed Enoxaparin for venous thromboembolism prophylaxis. Which of the following findings would indicate a possible adverse effect of this medication? Now let's carefully go through the options. Option A, thrombocytopenia. Option B, elevated liver enzymes. Option C, bradycardia. Option D, hypokalemia. Think critically about what Enoxaparin is known to cause and how those effects show up in your client assessments. The correct answer is Option A, thrombocytopenia. Let's walk through why this is a serious and potentially life-threatening concern. Enoxaparin is a low molecular weight heparin used to prevent and treat venous thromboembolism. But one of its most significant adverse effects is heparin-induced thrombocytopenia. This is an immune-mediated reaction in which the body forms antibodies that activate platelets, paradoxically increasing the risk of clotting while platelet counts drop. This typically occurs 5 to 10 days after starting the medication. If not recognized early, it can lead to life-threatening thrombotic events, such as deep vein thrombosis or pulmonary embolism. Nurses must monitor platelet counts regularly during therapy and report any significant drop, especially more than 50% from the client's baseline. Option B, elevated liver enzymes, can happen with many drugs, but it is not commonly associated with enoxaparin and is not a routine concern with this therapy. Option C, bradycardia, is unrelated to enoxaparin's action, as it has no effect on heart rate or cardiac conduction. Option D, hypokalemia, is more commonly seen with diuretics, insulin, or gastrointestinal fluid loss, not with anticoagulants like enoxaparin. Clinically, enoxaparin is administered subcutaneously, usually in the abdomen. Nurses should avoid expelling the air bubble in the syringe or massaging the injection site to prevent bruising. It does not require activated partial thromboplastin time monitoring, making it convenient for use in both inpatient and outpatient settings. However, it is contraindicated in clients with active bleeding, thrombocytopenia, severe hypertension, or those who have recently had spinal or epidural procedures. If bleeding becomes a concern, protamine sulfate can be used as an antidote. This question reinforces the importance of monitoring not just vital signs but also laboratory values that can point to dangerous complications, something every nurse preparing for the NCLEX should be confident with. Let's turn our attention to pediatric emergency care, with a focus on managing pain in clients with bleeding disorders. This scenario highlights the importance of choosing medications that are both effective and safe when clotting is impaired. Think like a nurse. Here comes question number 14. A 16-year-old adolescent is brought to the emergency department after sustaining a fall at a skating rink. The client reports severe knee pain and swelling, and the nurse confirms a medical history of hemophilia type 8. Which of the following medications would be the most appropriate choice for pain relief in this client? Let's review the options closely. Option A, meloxicam. Option B, acetyl salicylic acid. Option C, indomethacin. Option D, codeine phosphate. When answering, think about which medication manages pain without increasing bleeding risk. The correct answer is option D, codeine phosphate. Here's why this is the safest and most effective option in this situation. Codeine phosphate is an opioid analgesic that provides reliable pain relief without interfering with platelet function or coagulation pathways. This is critical for a client with hemophilia type 8, which is a deficiency of clotting factor 8, leading to a significantly increased risk of bleeding, especially into joints. In cases of trauma like a fall, the client is at high risk of hemarthrosis, where blood accumulates in the joint space, causing swelling, pain, and reduced mobility. Managing pain is essential, but it must be done in a way that does not worsen the underlying clotting disorder. Option A, meloxicam, is a non-steroidal anti-inflammatory drug that inhibits platelet aggregation and should be avoided in all clients with hemophilia. Although commonly used for musculoskeletal pain, it poses a serious bleeding risk in this context. Option B, acetyl salicylic acid, also known as aspirin, is even more dangerous in this population, as it irreversibly inhibits platelet function. Aspirin is strictly contraindicated in all forms of hemophilia due to the severe risk of uncontrolled bleeding. Option C, indomethacin, is another non-steroidal anti-inflammatory drug with potent anti-inflammatory properties. But like others in its class, it affects platelet activity and should be avoided in any client with a bleeding disorder. Clinically, hemophilia type 8 management includes replacing clotting factor 8, particularly during bleeding episodes or after trauma. Supportive measures such as rest, ice, elevation, and immobilization are also essential. But when it comes to pain management, opioids like codeine or morphine are the medications of choice because they control pain without compromising clotting. This type of NCLEX question tests not only pharmacologic knowledge, but also safety and client-specific considerations, skills that are crucial in everyday nursing practice. Let's explore a foundational anticoagulation question that is a favorite on the NCLEX, especially when it comes to understanding which lab values correspond with which medications. When administering a continuous infusion of unfractionated heparin, it is absolutely essential to know what you are monitoring and why. Let's keep those answers coming. On to question number 15. A client has been prescribed a continuous infusion of unfractionated heparin for treatment of multiple venous thromboemboli. The nurse understands that the primary goal of this therapy is to achieve which of the following therapeutic targets. Let's now examine the options. Option A. Increase the international normalized ratio to 2.5 to 3.5. Option B. Prolong the activated partial thromboplastin time to 1.5 to 2.5 times the normal control. Option C. Maintain a platelet count between 500,000 and 600,000 per cubic millimeter. Option D. Decrease the D-dimer level below 100 nanograms per milliliter. Take a moment and think about which value directly correlates with heparin's anticoagulant effect. The correct answer is option B. Prolong the activated partial thromboplastin time to 1.5 to 2.5 times the normal control. Let's understand why this is the correct therapeutic goal. Unfractionated heparin is an intravenous anticoagulant used for rapid anticoagulation in acute settings, such as venous thromboembolism, pulmonary embolism, or myocardial infarction. Its effect is monitored using the activated partial thromboplastin time, which measures the efficiency of the intrinsic clotting pathway. The target range for therapeutic anticoagulation is 1.5 to 2.5 times the client's baseline or the laboratory's standard control value. This ensures that the blood is thinned enough to prevent further clot formation, but not so much that it causes dangerous bleeding. Option A, international normalized ratio, is incorrect because that lab value is used to monitor warfarin therapy, not heparin. Heparin does not affect the international normalized ratio and should not be adjusted based on it. Option C, maintaining a platelet count between 500,000 and 600,000 per cubic millimeter, is not a therapeutic goal. In fact, such a high platelet count would be abnormal. And the real concern during heparin therapy is a significant drop in platelets, which could indicate heparin-induced thrombocytopenia, a serious immune reaction. Option D, D-dimer, is a diagnostic tool used to help detect the presence of a clot, but it is not used to monitor heparin's effectiveness and does not guide dosage adjustments. Clinically, activated partial thromboplastin time should be drawn about every 6 hours until it stabilizes in the therapeutic range, and then at regular intervals. Heparin's short half-life allows for rapid adjustments, which is why it's so useful in acute care settings. Nurses should always watch for signs of bleeding, monitor platelet counts for signs of heparin-induced thrombocytopenia, and know that protamine sulfate is the antidote for heparin overdose. This type of question tests your ability to connect pharmacology with lab interpretation, a vital skill on the NCLEX and in clinical practice. Wait a moment before we continue. This could change your entire NCLEX prep. Our complete NCLEX review course includes 100 hours of animated lectures, 500 hours of deep dive teaching, 5,000 powerful practice questions, 500 NGN-style case studies, and 15 full-length exam simulations. You'll also receive a full-access NCLEX ebook for 12 months. The course is now 70% off, but not for long. Tap the link in the description and get started right now. Let's now revisit an essential safety concept in medication administration: monitoring the right laboratory values to catch adverse effects early. With anticoagulants like Enoxaparin, knowing what to monitor can make the difference between timely intervention and a life-threatening complication. This one's a favorite for test makers. Question number 16. A nurse is reviewing laboratory data before administering the next scheduled dose of Enoxaparin to a hospitalized client. Which of the following laboratory values is most important to monitor for potential complications related to this medication? Take a moment as we go through the options. Option A, serum magnesium. Option B, hemoglobin, A1C. Option C, platelet count. Option D, creatine kinase, MB. Think about which laboratory result directly relates to enoxaparin's most serious and potentially fatal adverse effect. The correct answer is option C, platelet count. Let's take a closer look at why this is the most critical laboratory value to monitor. Enoxaparin is a low molecular weight heparin used to prevent or treat venous thromboembolism, including deep vein thrombosis and pulmonary embolism. It is commonly prescribed after surgery or during periods of immobility. While it does not require regular coagulation monitoring, like activated partial thromboplastin time or international normalized ratio, the major safety concern with this medication is the risk of heparin-induced thrombocytopenia. This is an immune-mediated reaction in which the platelet count drops significantly, usually by 50% or more, and paradoxically increases the risk of clot formation rather than bleeding. Monitoring platelet counts, particularly within the first 5 to 10 days of initiating therapy, is essential to detect this complication early. Option A, serum magnesium, is important for neuromuscular and cardiac function, but is not affected by Enoxaparin and is not relevant to its safety profile. Option B, hemoglobin. A1C is a measure of long-term blood glucose control and is not impacted by anticoagulants. Option D, creatine kinase MB, is a cardiac enzyme used to diagnose myocardial infarction, but it does not provide information related to the effects or safety of Enoxaparin therapy. Clinically, Enoxaparin is administered subcutaneously, typically into the abdominal area, and should be given using the full pre-filled syringe without removing the air bubble. This helps reduce bruising and ensures proper medication delivery. If serious bleeding occurs or an overdose is suspected, protamine sulfate is the reversal agent used to counteract enoxaparin's effects. Remember, while laboratory monitoring for clotting times is not necessary with enoxaparin, platelet count monitoring is essential. Questions like this are highly testable on the NCLEX because they reinforce the nurse's role in preventing complications and ensuring medication safety.
Let's now focus on a chemotherapy safety question that emphasizes one of the most important responsibilities of a nurse: preventing infusion-related complications with high-risk medications. Chemotherapy agents like Cisplatin require very specific assessments to avoid serious harm, especially when given intravenously. Let's take your knowledge one step further. Question number 17. The nurse is preparing to administer Cisplatin, an intravenous chemotherapy agent, to a hospitalized client with metastatic cancer. Which of the following assessments is most important to complete prior to initiating the infusion? Let's break down the options carefully. Option A, confirm intravenous site patency. Option B, review the client's recent body weight trend. Option C, check for history of nausea and vomiting. Option D, assess the client's pain score and tolerance. Think about which assessment is most urgent to ensure the safe administration of a vesicant drug. The correct answer is option A, confirm intravenous site patency. Now let's understand why this is the highest priority. Cisplatin is a vesicant chemotherapy agent, meaning that if it leaks outside the vein into surrounding tissue, a process known as extravasation, it can cause severe tissue damage, including necrosis, blistering, and permanent injury. Ensuring that the intravenous site is fully patent and functioning properly is the most critical step before initiating the infusion. Ideally, vesicants should be administered through a central venous access device. But if a peripheral line is used, the nurse must be especially vigilant. Any signs of infiltration such as swelling, redness, or pain at the site should immediately delay the infusion. Option B, reviewing the client's recent body weight trend, is important for overall cancer care, fluid status, and nutrition monitoring, but it does not impact the immediate safety of Cisplatin administration. Option C, checking for a history of nausea and vomiting, is useful because Cisplatin is highly emetogenic. However, pre-medication with antiemetics is already standard protocol, so this information does not take priority over checking intravenous access. Option D, assessing pain score and tolerance, is always a part of comprehensive nursing care, but it does not directly affect whether Cisplatin can be safely infused. Clinically, Cisplatin carries significant risks such as nephrotoxicity, electrolyte disturbances, especially with magnesium and potassium, and nausea. Clients should be prehydrated and given antiemetics prior to treatment. Nurses must also educate clients to report burning, stinging, or swelling at the intravenous site immediately, as these could be early signs of extravasation. This type of NCLEX question highlights the nurse's role in preventing complications from high-alert medications, a core aspect of patient safety in oncology nursing.
Let's wrap up with a question that highlights the importance of clinical judgment and safe medication practices when managing anticoagulants, especially during the overlap phase of therapy. Many clients with venous thromboembolism are started on both heparin and warfarin, and it's essential that nurses understand how and when each medication should be adjusted. Pay close attention. This is question number 18. A newly hired nurse is assigned to care for a hospitalized client diagnosed with a venous thromboembolism who is receiving both continuous unfractionated heparin infusion and oral warfarin. Which of the following statements by the newly hired nurse would require immediate follow-up by the preceptor? Let's take a look at the options. Option A, I will monitor the client's stool for any signs of occult blood. Option B, warfarin should be continued even after discharge to prevent recurrence. Option C, both medications will require lab monitoring until therapeutic levels are reached. Option D, we can discontinue the heparin infusion as soon as the INR reaches 4.0. Think about which of these responses reveals a misunderstanding of anticoagulation management and could place the client at serious risk. The correct answer is option D. We can discontinue the heparin infusion as soon as the INR reaches 4.0. Here's why this statement requires immediate correction. An international normalized ratio of 4.0 is actually considered supratherapeutic for most clients being treated for venous thromboembolism, where the target range is typically between 2.0 and 3.0. At an international normalized ratio of 4.0, the client is at significantly increased risk of serious bleeding. Furthermore, the decision to discontinue the heparin infusion should never be based solely on the international normalized ratio, and it should always be done under a provider's guidance. Warfarin takes several days to reach a therapeutic level due to its effect on vitamin K-dependent clotting factors, and that's why it is overlapped with heparin. Heparin provides immediate anticoagulation while warfarin builds up to a therapeutic level, and it should only be stopped once the international normalized ratio has been within the target range for 24 to 48 hours, and the provider has given the order. Option A is appropriate and reflects good practice, as clients on anticoagulants are at risk of gastrointestinal bleeding, and monitoring for occult blood in the stool is part of ongoing safety assessments. Option B is also accurate. Warfarin is continued long-term to prevent recurrence of thromboembolism, typically for 3 to 6 months or longer, depending on the client's risk profile. Option C is correct as well. Laboratory monitoring is essential for both medications. Activated partial thromboplastin time for heparin and international normalized ratio for warfarin. Clinically, nurses must also watch for signs of internal bleeding such as hypotension, tachycardia, abdominal pain, or altered mental status, especially when the international normalized ratio is elevated. Protamine sulfate is the antidote for heparin, and vitamin K or fresh frozen plasma may be used to reverse warfarin if bleeding occurs. This type of NCLEX question tests both pharmacology knowledge and safety awareness, 2 areas nurses must master to provide excellent care. You've made it through today's essential hematology pharmacology review. Great job staying focused and committed. Remember, mastering these medications isn't just about passing the NCLEX. It's about being the kind of nurse who thinks critically and acts safely. We'll be back with another high-yield video very soon, so make sure you keep watching and stay consistent with your prep. We cover crucial NCLEX topics like this every single day, bringing you fresh videos packed with the most important concepts and exam-style questions to help you succeed. If this video helped you, follow us, turn on notifications, and make us part of your daily study routine. Because the more you engage, the closer you are to achieving your dream of becoming a nurse. See you in the next video.